Hello, everybody. So I am currently in Alabama, and as you can see, I'm in my granddaughter's room. I know, cute little pink walls. So I hope that you're able to access this recording. I will insert some key notes and phrases for you to report back to me so that it will allow me to count that as your grade. So let me get the lecture pulled up for you. Let me share that with you. So we have moved into special populations. And we will talk a little bit more about what special populations means for you. So hopefully that will help you have a really good understanding of how special populations play a role in the OR setting, how you will be responsible for specific populations and caring for them differently than the normal population. So we're going to jump right into that. So at the end of this, here's what you will be able to do. Compare and contrast the surgical care considerations for pediatric patients, which is one of those subsets of population that is special. They have a lot of special needs in the OR. Patients who are obese, patients who are diabetic, pregnant, immunocompromised, disabled, geriatric, or experiencing trauma. And you may think right off the bat, I don't know what experiencing trauma how that would be a special population, but we're going to talk about that and you'll understand that a little bit better. Also, being able to evaluate the unique physical and psychological needs of each of those special populations, because that is something that does come into play. You're also going to be able to compare and contrast the intraoperative considerations for those patients. You may think about, okay, so the pre-op is a little bit different. But the intraoperative is as well, just the surgical care considerations and then the intraoperative of all of those. And then evaluating your role for each of these populations. Also assessing the ethical commitment that's required of you as it relates to special population care, and then determining general needs associated with these special populations. So what is a surgical patient with special needs? These are patients that are outside of what we consider the normal population. And they do present some challenges that vary. It could be some physical needs that are presented or psychological needs. And we'll see that a lot with pediatrics and drug abuse and different populations. And so we have to adjust our care to meet their needs, because the saying that we always say is meet the patient where they are. If you are an adult and your patient is a pediatric patient, they do not understand you if you speak to them as you would another adult. So you have to meet them where they are. You have to speak to them as if they are, as if you are on their level, so that you're meeting them where they are. Same thing with psychological needs, with like we talked about, in the last chapter, with different levels of spiritual needs, the safety needs that we have spoke about, so that's something that we have to consider with all patients. but there's a lot of psychological needs that you will be addressing on a regular basis. We've already talked about what those special needs groups are. We'll take those into a little bit deeper. So let's start with the pediatrics. Pediatric means between birth and 18 years old. The breakdown of each one of those is in your book. You can look at what infancy stage is, adolescent, adult. All of those stages are broken down in a table in your book. And so this is important to know if you have a case coming in and they say it's a toddler, and it'd be nice to know what age bracket that means. There's many reasons for pediatric patients to be needing surgery, but they fall into 3 categories. One is congenital, so they were born with this condition. They are needing possibly repair of a congenital disorder or deformity, things of that nature. Then they could be a disease. So we could be looking at cancer. We could be looking at a respiratory or cardiopulmonary disease that could have been related to congenital, but then evolved into a disease of its own. And then trauma, of course. Children are involved in trauma cases such as motor vehicle accidents, any kind of injury, drownings, near drownings, a variety, falls, abuse is a large one. And so those are the 3 categories that all of the surgical reasons will fall under. Now, we're going to focus primarily on the unique problems and the challenges of each of these patients, because we want those patients to feel unique and to feel that they have our full attention, because especially with pediatric patients, we are immediately working to build trust and rapport, and you kind of look like a person in a spacesuit because, especially with COVID, we have an excessive, it feels like to someone looking on, excessive amount of facial coverings. Even in the OR, you're gonna, if they're awake at that point, which a lot of pediatrics will not be, all the staff has on goggles. So goggles, mask, gown, glove, hair covering, that looks pretty scary to a pediatric patient. So it's important in the pre-op interview that rapport is made, that that there is a forming of trust so that the patient has the best outcome. Now we will talk about how that certain things are approached in that pre-op interview, and how things like anesthesia are addressed. There's also a lot of anatomical and physiological differences in pediatric patients that are different than an adolescent and even an adult. And those are in your book in tables 4, 1, 2, and 3. And so in those tables, it talks about temperature regulation is different. And so, that's going to be addressed. We're going to talk about how that's addressed, but also even like monitoring their vital signs is going to be different. So looking at how that anesthesia is going to be paying attention to those pediatric patients. You may get used to seeing adult numbers, and then when you see, pediatric numbers, you may be a little concerned with the big difference that pediatric vital numbers have compared to adult numbers. So just looking at those tables, it'll give you an idea about how that difference will present itself there. And there's a lot of psychological factors that must be accounted for. So thinking about what a child is going to be experiencing. One, their number one thing is separation anxiety, because they're being separated from their parents who they have the most trust in. And so there are some ways to reduce the child's anxiety level. Sorry for the yawning, I'm extremely tired these days. To make things enjoyable and fun. I know that we used to make balloons out of gloves, so taking a glove, pulling the hand part of it together, blowing it up, making a balloon for the pediatric patients was always kind of a big hit as far as looking at giving them a little bit of fun, because and then giving them something is always a way to kind of help reduce a little bit of that anxiety. Some kids will not have anything to do with it. They're going to override you and they're going to continue with their anxiety. They're also afraid of the anesthesia, because if they are old enough to know anything about what is happening, just like adults, they may be afraid of falling asleep, because what if I still fall asleep and I don't wake up? What if I fall asleep and my parents aren't here? Because one of the greatest fears of children is that they lose their parents. And so it is known that one of the fears of children going into under anesthesia is that their parents will no longer be there when they wake up. And so there are ways to try to reduce that anxiety for the children. I've got a couple of videos for you to watch about how that anesthesia will carry out that process to try to ease the anxiety of the children. So we're going to watch a couple of those.
Inhalational induction. The patient is positioned on the parent's lap.
And so this is pretty common that a parent hold a pediatric patient while the initial anesthesia induction is carried out. And so this, of course, is not the OR, but it is the pre-op area where the patient will be taken to a certain level of sedation and then transported into the actual OR. So the parent will be used as a comforting technique to help get the patient under sedation.
Or on a trolley dependent on age. Position the stool for the parent and patient so the anaesthetist can reach both the patient and the anaesthetic machine easily. Showing the mask can sometimes reduce anxiety in child and parent. Apply saturation monitoring only if it does not upset the child. Gently introduce the anaesthetic gases via a cupped hand or place the mask gently over the child's face with their cooperation if possible. 100% oxygen is best. If available, nitrous oxide may be added. Start with low vapour concentration. Here, sevoflurane is used. Gradually increase vapour concentration. Increase after a few breaths at each concentration. This helps tolerance of vapour. If the child struggles, gently maintain mask seal and increase the vapour concentration to the maximum. Any breath of room air will prolong the induction. Keep watching the airway and bag movement as anaesthesia gradually takes hold. Support the back of the child's head as the induction progresses and consciousness is lost. Maintain a good face mask seal. Assistants should apply saturation as soon as possible. Coordinate.
So this may be something that you are partnering with anesthesia in certain facilities is what they were just saying. The assistant is now going to place the pulse oximeter on the child because they have lost consciousness, and you will watch the anesthesiologist is going to continue to keep very tight seal on that face mask, because if they allow one breath of room air in, it could reverse it because this patient is barely under at this point.
A smooth transfer to the trolley at this point and stop nitrous oxide if running. The parent now leaves. Hold the airway and keep the anaesthetic mask and circuit on the patient at all times. Continue with basic airway management. So what the anesthesiologist is doing here is they're seeing how much this, so the patient is still breathing on their own. They're sedated. They're not that deep under to where that they do not breathe on their own. So there's different levels of sedation. And this level, they're still breathing on their own. And you can see that it's inflating the bag. And progress to a deeper level of anaesthesia through any excitatory stage. CPAP is always helpful here. Always closely watch patient and movement of the bag. Apply monitoring as soon as possible. And so applying all of this monitoring equipment while the patient is awake would be impossible. So as soon as the patient is asleep, then you will see the monitoring equipment will be placed on the child. And you can see that technique is very effective, where the child is being held by the parent while they are initially being taken under anesthesia. So let's watch this second one. And this is an older child. iGel, IV induction, apnea. Prepare equipment and drugs before the child arrives. Give explanation and reassurance to child and parent. Apply saturation monitoring, ECG, and non-invasive. And you can see with the older child, and they're able to understand what's happening a little bit more, but they're still going to be very nervous about the process, but they are able to kind of help you out or help the circulator that's applying all of the monitoring equipment. Blood pressure. Position the anaesthetic trolley close to the anaesthetic machine. With explanation, parental presence is often calming for parent and child. An older child will usually tolerate pre-oxygenation. An intravenous cannula has been placed. Commence induction with explanation and reassurance as loss of consciousness occurs. After induction of anaesthesia, the airway needs support as airway tone changes. The parent leaves after consciousness is lost. Note head position on the pillow and anaesthetist's support of the airway. The child is apneic after propofol. This is not unusual. Gently inflate chest and confirm. So the medications that were used are different. So this medication will actually cease spontaneous breathing. So then it will have to be monitored. So that's why they are inflating the bag to provide that air, that breath. So you can see the difference in the two ways that children are being placed under anesthesia. So you have a young child that may be held by the parent
for that initial phase, and an older child who the process can be explained to and they're understanding and they're a lot more cooperative, but the parent is still able to stay in the room until the child is under anesthesia, because there's still a fear of anesthesia even at that older age. And then of course, monitoring is going to be very different, as we spoke about between the pediatric and the adult patient. You're going to see a lot of difference in the vitals, and anesthesia will be aware of that. And just want to let you, we're just letting you know this because you will see some differences. So some critical parameters: temperature. Temperature regulation is different for pediatrics. An example of that, babies are not able to shiver until around the age 6 months. And so it's important to monitor the temperature of babies under 6 months, so that that can be monitored without relying on noticing physical output. Urine output is very important. Pediatrics can dehydrate very quickly, and so that's really important to be monitoring the urine output as well as fluid loss. So anesthesia is going to be checking in with you on how much fluid loss has been calculated on your side, including blood loss, any irrigation that you're providing the physician is going to be in the input. So they're going to be constantly weighing that input and output. Cardiac function is something that is monitored, especially, there's a lot of pediatric cardiac patients that you may be in on some of those cases. It is challenging to get some monitoring done for the cardiac function. So there's some special procedures that are done. I've got a couple of videos here for you to watch some of those lines being placed. So one is a central line being placed on a pediatric patient. I'm not sure if I got the arterial line. It's an intravenous arterial line. So that gives them access to the arterial system, which allows to monitor that cardiac function. So an arterial line will be able to actually monitor how well the heart is functioning with the output and the pressure that's in the chambers. So we're going to watch those videos of a couple of these lines put in.
Inhalational induction.
Oh, that was the same one. Okay, let me get back over here. So this is the arterial line
proximal to the insertion site. Inadequate collateral circulation.
So I have forwarded this already to the point where I felt like it was important. So these are some contraindications for an arterial line placement. An arterial line is going to be placed usually in the radial artery, so which is basically in the wrist. It could be in the brachial artery, which is in the elbow. It could be in the femoral artery, which is in the groin. Contraindications: infections at the insertion site, traumatic injury, proximal, meaning towards the body, and inadequate circulation to the extremity. So I want you to be familiar. I just want you to see this so that it's not your first time, because these procedures are things that are done in the OR, because it's impossible to do these at bedside, because the pediatric patient is not going to hold still for you.
Of the extremity indicated by a failed Allen's test. Complications. The complications that you may observe include the procedure. Equipment. You will need the following equipment to perform the procedure. Arm board.
Let me move this bar out of the way.
tape, chlorhexidine prep solution, arterial catheter, guide wire. We must make sure that the guide wire fits through the catheter. T-connector, sterile occlusive dressing, sterile gloves, sterile towels, transducer system, saline flush. Techniques.
Basically, there are two types of techniques for obtaining peripheral arterial access. The first is known as the slide off or thread off technique, where we place a catheter in the artery, a catheter and needle system in the artery, and then we actually, once we obtain access, we slide the catheter off the needle into the artery. The other technique is known as the through and through technique, where we use a needle and catheter system to actually intentionally go through both the anterior and posterior wall of the artery. And then we actually we remove the needle from the catheter, pull the catheter back to the point where just the catheter is in the artery, and we have obviously arterial blood coming out of the catheter. And at that point, we insert a guide wire through the catheter, which is then going to come out the end of this catheter, and we use that as a guide to thread the catheter off into the artery. If you decide to use this thread off technique or slide off technique, you're going to approach the artery at a much shallower angle than you will if you intentionally do a through and through technique. And obviously the advantage of approaching at a shallow angle is it's much more amenable, once you get flow, to threading the catheter off into the artery. Whereas you can see in this technique, it's very unlikely that you're going to get a catheter to thread off a needle at a steep angle like this. When you decide to go with this technique, it's important to remember that if you're unsuccessful at threading the catheter off, it's best to remove the catheter, hold pressure for a little bit, and then reattempt again using that same technique, if that's the technique you're going to use, rather than doing what people will oftentimes try to do, which is to convert this thread off technique to a through and through technique. And the problem with doing that is, if you imagine that I go at this shallow angle and attempt to pierce the posterior wall of this artery, you can see that this is very different than this. And the difference is subtle but important. At this shallow angle, if I go through the posterior wall of this artery, I'm going to raise a much bigger flap of intima on the posterior wall of this artery than I am if I go through at this steep angle. And the problem with trying to convert this technique to a through and through technique is that when I then go through and through and I pull the catheter back looking for blood, and I'm sitting right here, when I then go to place the guide wire through this catheter, the guide wire is going to be directed directly at the area here where I raise the intimal flap. And the likelihood that I'm going to get the guide wire to avoid the flap and track up this way is very small. It's important at the outset to decide which technique you're going to use and stick to it.
Placement sites.
So when we think about the sites available for blood pressure monitoring, we tend to think about peripheral sites versus central sites. And when we talk about peripheral sites, probably the most common peripheral site would be the radial artery. And the reason that that's a popular choice is that it's easily accessible. The pulse is generally easily palpated there. Even in most circumstances of low cardiac output, it's relatively easy to feel a radial artery pulse. And the other is that the hand, which obviously is supplied by the radial artery, has good collateral circulation from the artery on the other side of the arm, which is the ulnar artery. And in fact, the ulnar artery is bigger generally than the radial artery. So when we put a catheter in the radial artery, we're really potentially compromising the smaller of the two arteries to the hand, which is supplied via the palmar arch from both the radial and the ulnar artery. The other peripheral sites that we commonly think of would be the dorsalis pedis artery here on the dorsal aspect of the foot. And the other would be the posterior tibial artery. And again, the reason that those two sites are popular is that because there are two relatively major arteries to the foot, if we catheterize one of the arteries, we have good collateral flow from the other remaining artery. The other peripheral site that's a potential area for arterial catheterization is the brachial artery, although in our experience, that's probably the least popular site we're going to talk about. And the reason for that is that the brachial artery is the sole blood supply to the entire distal part of the arm before the brachial divides into the radial and ulnar artery. So if we compromise the brachial artery, if it thromboses, if it goes into spasm, it's a relatively small artery that provides the total blood supply to the arm. And so we're going to walk through putting in a radial arterial line. And the first thing we need to do is establish that there's good collateral flow through the ulnar artery before we decide to put a catheter in the radial artery. And there are a number of ways to assess the adequacy of collateral flow, but really the simplest is our patient has a pulse oximeter on their hand, and what I'm going to do is I'm going to completely occlude the radial artery pulse with my fingers here. And then I'm going to look at the pulse ox trace. And as long as the pulse oximeter trace continues, I know that there has to be good collateral flow through the ulnar artery, so that even in the worst case scenario, if I completely occluded the radial artery, this child would continue to have flow to their entire hand through the ulnar artery.
Point of clarification. It is very important to establish collateral flow before attempting arterial line placement. If the patient is unable to cooperate, you will have to occlude the artery.
Now,
For optimal wrist positioning, place the patient's arm on a board with a roll of gauze pads underneath the dorsal part of the hand to create about a 45-degree angle. This is important in order to provide comfort to the patient as well as good exposure to the radial artery.
we're going to assume, for the sake of this demonstration, that our patient is well anesthetized, and we're not really going to talk about sedation or analgesia for placement of this catheter right now. So I've washed my hands and put on a pair of sterile gloves, and we're now going to prepare the radial artery for arterial cannulation. So what I'm going to do is I'm going to prep the skin here and then drape it with the sterile towels. I'm going to get my ChloraPrep organized, and I'm prepping the skin. And I've left myself a really wide area here so I can see the good part of the arm and the artery, and I'm prepping a nice wide area.
And the reason that I want you to see this is because there's many cases where this is done at the beginning of your procedure. So your doctor hasn't even scrubbed in yet, or they're not ready to gown and glove. They're just doing an open glove technique where they're performing this prior to the procedure.
And then I'm going to take my towels, and again, I'm going to do this in a way so that I leave myself lots of room. There's no point in trying to do this through a really tiny little hole. And I'm going to use all 4 of these and make a nice little square so I can see what I'm doing.
Point of clarification. Remember, a timeout should be performed prior to any invasive procedure.
So we've got our patient prepped and draped here, and what I'm going to do is I'm going to demonstrate now the method for using the slide-off technique for putting this radial artery catheter. And you can see I have a needle catheter over a needle system here. So this will just slide off. And this is a 22 gauge catheter.
It is important to select the size of the catheter based on the size of the patient. 24 gauge catheters are used for infants, 22 gauge for toddlers, 22 to 20 gauge for small children, and 20 to 18 gauge for larger children and adults.
And remember, as we said earlier, for the technique where we slide the catheter off, we're going to go at a very shallow angle. So I'm going to be at an angle like this, as opposed to an angle like this if I were going to intentionally go through and through the artery. And you can imagine how that, in order to be able to thread this off, going at this shallow angle like this, it'll be much more likely that I could thread the catheter off. So what I'm going to do is feel the pulse here and orient myself with the catheter at a relatively flat angle. And then I'm going to be looking for blood return in the top of this catheter. Some people will flush the catheter with saline as a way of enhancing the ability to see a flash of blood. You can see that there's a little flash of blood there in the hub of the catheter. And now what I'm going to do is I've still continue to have flow here, so I ought to be able to thread this catheter off right into the artery, which we've done. And then I have my connector, which I have clamped here, and I also have a little cap on the end of it. And what I'm going to do is I'm going to take the needle out now and hook this up to my connector. And you can see I have the free return of blood there.
Please note that when connecting the T-connector to the transducer system, it is important to ensure that no air bubble is introduced.
So I'm hooked up now, and I can then stabilize this with my occlusive dressing, like so. And then what I can do, now that I have control of this, is unclip this, and I'll have blood coming back through my connector to here. And now we'll be ready to hook this to the transducer system.
The use of a heparinized or unheparinized saline flush is necessary to ensure that good arterial blood flow can be drawn back and flushed through the T-connector system.
And so at that point, you would be asked for the heparin to be handed to the surgeon for that flushing. Okay. All right. Okay. And so that is the cardiac function procedures. And then there's also a central line. I thought I had that one for you. So let me stop the share real quick and grab that, because I know I had a good. Here we go. Okay. Let me share this with you again, because this is a good demonstration of a central line insertion, because I want you to be familiar with this, because you will be responsible for having this kit ready for the patient, more than likely, because they're also going to do what's called they may do a cut down. It's called a cut down. That's where they go in to the vein and insert the IV. And the central line is one variation of that, but cut down may be where they cannot get a IV on a pediatric patient. So they'll wait till they're in the OR and then do a cut down procedure on them. But I want you to be familiar with this central line placement, because this this may be something that would be on your back table or mail stand for you to have ready for these patients. This is not the procedure I watched earlier, so let me pause a moment, see if I can find this. Actually an excellent one. It was really good. I've got to find it now. It's going to bug me, or we're just going to watch that one. Guess we have to watch that one. This one is also going to be done on a I apologize. I'm going to find the good one. I apologize for my dogs. They are snoring like crazy. Here we go. Now I found her. This lady is excellent at explaining.
Hi everyone, Dr. Siddiqui here. Today we're going to be talking about central lines, how to place a central line, some of the indications for it, and some complications that could go wrong when you place the central line. So let's get started. Okay, so key things are, you want to cover from here. Whenever you do any procedure, you want to put on your mask. So you see how there's a little tip on this side? Makes it easy. So we open it up.
We have some of these kits in the vault, and the lab instructors are going to be showing you these.
Like this, right? So then what we do is we take this out. Okay. This is going to serve as our trash can. So we drop it and put it right there. And then we open this. So we open this up. Just like this. Like this, and if you struggle, it's okay. And you pull like this. So we open this up. So this is our kit, right? You guys can come closer so you can watch. So this is what is going to go on the patient. What you want to do is you always want to check all your equipment, okay? So key things are, this is going to be your guide wire. So what you do is thread it in a little and take this top little one out. And you can see that this is your guide wire. So you always want to double check your blade. You can just drop it there. You want to make sure your blade works. Check all of your equipment. This is going to be your needle driver, so make sure it works, right? And then you have everything else. So we move this stuff, and a lot of them you don't need to use. So this is going to be your needle, right? So you move this out, and this is where the bevel is going to be always facing up, right? And you want to make sure you can aspirate. And this is going to be our triple lumen catheter. So you open all these up. We're going to draw up our lidocaine. You open up your lidocaine. Pop this open. So what you're going to do is take your, put in a little bit of air. You put this here, and so this is how I wanted you to hold it. You hold it as tight as possible, and then the needle goes in. So the hand needs to be as steady as possible. You're going to take your needle and you put it here. Now you have your lido all drawn up. We have our needle tip, and this is what's going to anesthetize our patient, that site. The other thing is, these are for later. We're going to keep all of those for later. And this is going to be our dilator, right? What I want you to do is squirt, open it up. Remember, you don't want to drop it in here. It's still not sterile. So open it up, take it out. Take out the little white tip. Push, you have to yeah. And then you're going to squirt it right in here. Don't squirt all the way. You got to gently squirt it in there. Did you see how it can squirt? Good. Okay, don't get too close to the sterile field. Oh, squirt all the way. Perfect. That's it. You can take it out of the field. And then what we're going to do is we're going to draw this up. So what you're going to do is you're going to check every port to make sure it's patent, because you don't want a faulty one, right? So you go like this, and you check to see if it's patent. Is it patent? It's patent. Perfect. Same thing. So you try it white, keep everything steady. You try the blue. You try the blue, and you check. It's patent, right? Perfect. And then you try your brown. Same thing. Check. Is it patent? It's patent. Perfect. So all your equipment works. So then you have your thing aside. So everything else you need, it's here. So here's your needle. You're gonna have it. Some people like to take it out once it's in the vessel, and then they put in the guide wire, but that can be tricky. So I'd keep it on nice and tight. And what is gonna happen is you go into the vessel, and then what you're gonna do is once you're in the vessel, you're gonna aspirate. So you're going to pull back so first of all, somebody's going to show you with the ultrasound where the vessel is, and I like to use this little tip, and it'll tell me exactly where that vessel is. So I'll push on it, make sure that I'm there. Once I'm there, then with the needle, I point down and go down, and I pull back and aspirate until I see blood. Once I see blood, I hold it steady. Then with my other hand, what I'll do is I will put in my guide wire. So the guide wire goes in through the top like this, and you guide it in, right? And what's going to happen is it's going to go through your needle, right? It's going to go in through your needle into the vessel, okay? So what you're going to do is then, so you go all the way, keep on going all the way. And what's going to happen is until you see the tip, you're going to see the tip to about here, you see the tip. Now you pull back, that's it, right? So then what you're gonna do is you're gonna hold the vessel and pull your needle out. So you pull your needle out, right? But you have to be very steady. You're keeping it in the vessel. So then what you're gonna do is with a guide wire, so let's hold it steady. So let's imagine if this is in the vessel right here, right? So while holding it steady, you're gonna put in your dilator, okay? So your dilator goes in, and then you may face a little bit of restriction there. So what you're gonna do is take your blade, and with the blade facing up, because you don't want to cut your wire or your dilator. With the blade facing up, you make an incision like this. So you cut on the vessel and you make an incision. Once you do that, then you can push your dilator and it goes in. Once the dilator is in, you pull it back out. You have to go all the way. So then what you're going to do is you're going to put your this in there, right? So you're going to go in, guide it, and you don't want to let go of your wire, okay? So as you go in like this, right? So what you're going to see is right here, you're going to start to see your wire, right? So you want to see it all the way. So right here is once I see my wire, then I'm going to hold the vessel and pull the wire out. And you have to be very careful when you pull it out. You want to not splash anybody because it's coming from blood, right? So you pull it out. Now your guide wire is completely out, and what you're going to do is you have marks here, right? So you want to be about at the 15th mark. You don't need to get close. I can always zoom in with them. That's good. So at the 15th mark is where you want to stop. So then what you're going to do is with this, you have this kit right here, the little blue, and you have a little white one. So you'll take this and you're gonna, so it's gonna be right here. So what you're gonna do is, this is where your 15th mark is, this is where the skin is gonna be. So you're gonna put this on just like this, right? And then we're gonna suture it. And then we'll show it to you how we suture it.
Right, so that is a central line placement, and I wanted you to see it because, like I said, with pediatrics, it will be done typically in the OR because the patient has to be sedated. Another critical parameter is oxygenation. It is a little more challenging to monitor that on pediatric patients just because of their resistance to that probe being on their finger or things of that nature. So once they're sedated, it's easy to monitor that, as we saw in one of the first videos where oxygen saturation monitor was placed on the patient after they had their first level of sedation. But it is definitely something we monitor very closely with pediatric patients because that is something that can change very rapidly. So we're at a point now where I'm gonna give you your first key word, and that is 20 ml max. That was in the central line procedure. There was I will show you right here, 20 ml max is a statement in this kit. So that is your first keyword. So make sure that you send me that first keyword, 20 ml max. Okay, another consideration that we want to always be aware of with pediatric patients is the risk of shock. So there's two different types of shock. There's septic shock, which is basically a systematic infection, usually caused by a gram-negative bacteria. It is more common in infants and children. Their blood volume that is being circulated is reduced, and so that is a major risk of being fatal. There, other than the gram-negative bacteria, there are some other causes like a UTI. One of the primary causes of UTIs is E. coli, and there's others. Upper respiratory infections, so a URI and then also a contaminated intravascular catheter. So again, that goes back to being very careful with your aseptic technique. Hypovolemic shock, this is another type of shock that is seen in pediatric patients, and that is a reduction in the blood volume as well. But the cause of this is usually dehydration. And we talked earlier about how the anesthesia is going to be tightly monitoring that input and output. And this is one of the reasons, is trying to prevent any level of hypovolemic shock. Fluids and electrolytes are going to be monitored really closely. Understanding changes in body fluids that occur before and after birth is important, because there is fluid loss immediately after birth. A lot of times, the fetus has been in fluid for 9 months. And so there are some pretty drastic changes that happen, but they are normal processes that happen. And those are going to be outlined on that table 4-4. Dehydration is not well tolerated in newborns and infants. And that's what we were talking about, that they can be at a risk of hypovolemic shock very easily. So the insensible water loss is the #1 cause of that. And so that's why there's a lot of really careful monitoring of that fluid input and output in a procedure with pediatrics, just making sure that there is no water loss that's insensible. Infection is another risk. And immediately after birth, there's going to be some colonization of bacteria on the skin and in the GI tract. And so, of course, then there's always a risk of it overpopulating and causing infections. Post-op infections are always a risk in all categories. Of course, the initial sign is going to be a fever. And then there's different medications that are going to be used. Neonates, infants, and children, those are all going to be candidates for antibiotics, with the exception of antibiotics of sulfonamides, chloramphenicol, and tetracycline. E. coli, or enterocolitis, is associated with antibiotic use. Enterocolitis can lead to an overpopulation of Clostridium difficile, which is called C. diff, which it can be a life-threatening complication of antibiotic use, especially in pediatrics. Looking at their metabolic and nutritional response, so of course the caloric requirement for infants is going to be much higher than in the children, than older children and adults. And then surgery, thinking about surgery and what it does, it requires a lot of energy, because the patient is having to constantly be in a healing process. Healing takes calories, and so surgery really increases that caloric requirement. G-tubes are often used post-op, especially if the procedure is of the GI tract, because you're going to bypass that. It's not going to be functional for a span of time. So to maintain that metabolic and nutritional status, a G-tube is probably going to have to be placed. We do have gastrostomy tubes to demonstrate for you guys in the lab sessions. Trauma, #1 cause of death in children are accidents. Most often results from blunt trauma, such as a fall or head injury from abuse. MVAs could be another cause of that blunt trauma. Now, some of the key differences in treatments are emotional reactions. as we talked about earlier, you know, with that separation anxiety, the fear, you know, the fear of abandonment, fear of the unknown, not knowing what's going on, just typically very emotional in the pediatric patients. And then, of course, like we talked about, the metabolic and nutritional differences is pretty significant. The priorities for emergency treatment in pediatric is, as with everyone, open and maintain airway. And then, of course, we're going to stabilize the spine, make sure that there's no injuries that can be caused. IV catheters, fluids, control the bleeding. So those are #1 priorities when we're talking about emergency treatment. You can read through more in your book about the trauma during birth. There's a lot of, finally, there's a lot of information about trauma during birth for both mother and baby. And one of the most common is a clavicle bone fracture. So as the fetus, as the baby is being birthed through that canal and that shoulder is being turned, bones are soft in infants, and so it's easy to break that clavicle bone, collarbone. Also could find some shoulder dystocia or torticollis, which that is affecting the muscular tone in the neck and shoulders. Torticollis is in the neck, and of course then the shoulder dystocia is in the shoulder. So just really affecting with the tone, the muscle tone and function. And then of course child abuse is a big role. Multiple traumatic injuries are usually seen. So let's move on to the next category, morbid obese patients. This is where the body weight is greater than 100 pounds, more than the ideal body weight. You know, there's going to be some challenges with carrying that extra weight for an extended amount of time. There is increased susceptibility to morbidity and mortality. Several physiological and disease conditions we see more prevalent in morbid obese patients, like coronary artery disease, diabetes, hypertension, myocardial hypertrophy, which means the heart is having to work extra hard because of their weight. And so then the heart is getting larger, which in turn is a problem because the heart walls are getting larger and it's putting more toll on the heart as a whole. Varicose veins, pulmonary complications, and GI complications. Transportation, so these are some things for you to consider of how you would want to be especially attentive to this population. Transportation is going to be, may need some adjustments. Transferring the patient to the operating table, it may take, you may need additional staff. You may need to use different techniques. There's some transportation techniques that can be used to make use of moving devices that will help cut down on the number of staff that's needed for that to happen. IV insertion can be complicated and administration, so that can be challenging on morbidly obese patients just due to that extra tissue causing the IV line to be very challenging to be inserted in the first place. So again, you may see those patients that the IV insertion is not done until they're in the OR and a cut down may be performed. Positioning patients may be challenging or need to be adjusted. So they may need to add width to the bed to accommodate that the extra tissue that the patient is needing supported, that's the word. Grounding placement, grounding pad placement, just making sure that it's in the correct position. Instruments used during procedures, so we may look at needing longer and deeper equipment, where we're talking about, forceps, hemostats, pickups, different things. Also, healing may be delayed, especially if a patient is diabetic. That is going to definitely delay the healing. So may see some of that. Bariatric patients, so we're talking about weight loss surgery. So there's a lot of risk, such as post-op wound infections, sorry, dropped my water bottle lid. So some risk that are involved with bariatric patients, because first of all, they're already morbidly obese, and then bariatric surgery is going to run some higher risk. They're going to have coronary artery disease risk, anesthesia risk, DVT risk, post-op positioning risk. So there's a lot more risk, because they're usually more than just that 100-pound overweight. They may be excessively overweight. Now, complications after gastric surgery, because of that extra tissue and that extra weight in that area, there may be some of these complications: abdominal catastrophes, internal hernias, volvulus, so that would be the intestines enclosing on each other, acute gastric distension. This is something that's important, especially during bariatric surgery. Many times gallstones are found and during any abdominal procedure. And so as a scrub, you kind of have to be prepared to be prepared for a cholecystectomy, cholangiograph maybe need to be done. And so just knowing that things can lead to extra procedures being done during bariatric surgery. Degenerative osteoarthritis, of course, that extra weight is going to put more pressure on the joints and cause degeneration of the joints. Diabetic patients. So this is of course, this is an endocrine system disorder that we'll get more into. It does affect the insulin production in the pancreas, because the beta cells have been destroyed, or their ability to work is being compromised. And it is often genetic. There's 2 major types, but there are additional as well. Type 1 is called insulin dependent, and type 2 is non-insulin dependent, diabetes mellitus. There's also type 1.5, which is it is a type 2 patient that is insulin dependent. Okay, and there are some considerations to take when performing surgery on diabetic patients, because their healing process is lessened. They also, many of them have diabetic neuropathy. So when you're positioning and placing supportive devices, you want to be aware of that and make sure that things are as comfortable as possible. Some complications that may be associated with your diabetes patients is just like we talked about with the pediatric surgery, takes more caloric requirement. And so it's going to affect that intake of calories, and therefore it's going to affect their insulin needs. Anesthesia always affects normal metabolic processes. So this is going to be something that's going to be especially monitored after surgery to make sure that the insulin levels are monitored closely, so that they can be adjusted as that metabolic rate returns to normal. Diabetic patients are at higher risk for some for some issues like tachycardia, so increased heart rate, nephropathy, so issues with the kidneys, dehydration, coronary artery disease. Of course, they're going to have delayed wound healing, hypertension. They're at risk of a heart attack, UTI, and infection. So pre-op, these are some things that are going to happen. There's going to be fasting glucose done. They're going to be looking at medication dosage, insulin. You're going to do everything you can to prevent pressure sores. And then intraoperative, of course, anesthesia is going to be monitoring everything, levels of glucose. And then something that may fall into your category is placement of the anti-embolic stockings. You may also have to do help with the intermittent compression stocking system. And then post-op, they're going to look at doing everything to prevent a DVT. They're going to provide nutrients and medication. Pregnant patients. So if a pregnant patient is having a planned surgery during the first trimester, that is not recommended and should be postponed. During the second trimester, if the fetus is stable and the surgery is something that's not going to affect the pregnancy, then that's a good time to do that. Third trimester, there's a 40% risk of causing a premature labor, and the uterus is very much enlarged, so it's going to displace all the organs. So that's going to cause some complication because the anatomy is not going to be like it would be without the fetus in place. Like we said, there's some anatomical changes that are going to happen with that fetus, with that uterus enlargement. Lab test results are always going to be skewed on pregnant patients because the hormones are constantly adjusting to the baby's needs. It is challenging to assess physiological status just because of that constant change in a pregnancy. Of course, after surgery, there's going to be a lot of monitoring to make sure that there is no ruptured membrane or vaginal bleeding that would indicate any kind of uterine irritability. And then, of course, anesthesia is the most important to prevent preterm labor. So that is why anesthesia is kept as short as possible in pregnant patients. So if you're in on a case where the patient is pregnant, be prepared for that case to go as fast as it possibly can. So you're really going to be on top of things. Immunocompromised patients. So for any reason where the immune system is decreased is an issue. So we're already fighting to keep infection at bay in a normal immunocompetent patient. But when we have immunocompromised, then we face even a greater task of really trying to prevent that infection. Different things influence age, disease, etc. And so some of the things that you can watch for that will help you thinking of protecting the patient. Some physical manifestations that you'll notice on immunocompromised patients are things like skin rashes or lesions, very painful joints. So you're thinking about skin rashes and lesions. So you want to be careful with the sheets and blankets to not rub, just because they're, a lot of times they are more prone to having rashes due to any exposure. Painful joints, so you're going to want to make sure positioning is very comfortable, malaise, nutritional status, cardiovascular complications. So another form of immunocompromise is acquired immunodeficiency syndrome. That is AIDS caused by the HIV virus. So usually there's opportunistic infections. So it's very important for you to make sure that you're protecting your patient from any excessive opportunities. At this point, I'm going to insert my second keyword. This is one of my favorite movies about AIDS patients and HIV positive patients is Philadelphia. So remember the second keyword is Philadelphia. Send me that. So now we have 20 ml max and Philadelphia. Okay, so the things for you to consider with these this population is the need for you to really be on top of your aseptic technique, as well as helping the team make sure that they are monitoring their own technique and you monitoring each other, because these this population of people are very dependent on others to help reduce those opportunistic infections. Now, if a patient is physically challenged or sensory impaired patients, this is another category we're talking about, and this is going to be an area of anxiety. So we've already got anxiety from the procedure, and then we've got hearing impairment. They may not be able to hear or understand you, and maybe their interpreter or their support system is not able to be there with them. Physical as well as visual impairment. Physical challenges, so you may be looking at some form of a disability, whether it's in movement or cognitive impairment. So a couple things to think about there with their anxiety level is going to be even more elevated than if it was just a surgery without any of these extra challenges. Now, isolation patients, so these are patients that are at risk or have been diagnosed with the condition that needs, that requires isolation. So there will be additional procedures taken on your part. Probably will be in a hood and suit for these type of procedures, because these microorganisms can be transmitted in several different ways, as you see among patients, from patients to hospital staff, from hospital staff to patients, from hospital staff to hospital staff. There's different routes of microorganism transmission, contact that can be direct or indirect contact, droplets, airborne, which is what we're dealing with right now with the pandemic, common vehicles. So it could be that it's on something, you touch it, you carry it to another part of the hospital, and the microorganisms are on that, or vector-borne, sorry, skip that. Fundamentals of care. So this is really important about frequent hand washing. Make sure you're wearing your gloves, gowns, eye protection, face shields, and wearing your mask. Now, you may think, well, I don't want to wear eye protection. Well, eye protection is now required in the ORs due to so many microorganisms being transmitted through blood being spilled into the eyes. Transporting the patient, you want to be especially careful in transporting the patient, but also in handling the surgical instruments, all the supplies and the linens that the patient has been in contact with. Geriatric patients, so this is anyone over the age of 65. They typically have some form of debilitation or physiological status is decreased. A lot of times, most older people over 65, the majority, not everybody, but the majority will have one or two comorbidities. So they may not just have heart disease, they may also have a hip replacement or diabetes or hypertension So there may be a pretty good variety. You can look at the table 4-5 to look at some of the physiological changes that happen in the elderly patient. We talked about the changes that we see with pediatric patients. You're going to see some of the similar changes in the geriatric patient. Now, substance abuse patients, this is a challenge of different types. There's serious behavioral problems, and then the level of communication is very challenging in substance abuse patients. There is almost always some comorbid psychiatric disorder. So you're not only just dealing with substance abuse, you're also dealing with the psychiatric disorder on top of it. So it's hard to say many times if it's the drug or the disorder that is causing some of the issues. And then trauma patients, we talked about it with pediatrics, but with all trauma patients, adult and beyond, they're very challenging because there may be multiple injuries that have been sustained. And so what that means for you is that you may be in a case of an orthopedic trauma case that we're also having to look at repairing ruptured spleens, lacerated livers, so it's not usually just one injury that you're having to assist with addressing. So you just kind of have to be prepared to assist on any type of surgical procedure during traumas. And in trauma, there's what's called the golden hour. And this is that hour following the injury that it is critical in really helping determine that patient's outcome, because the golden hour, it's about tissue perfusion, it is about oxygenation of the tissue and making sure that intervention happens as quickly as possible, because that really does help reduce both the morbidity and mortality. There's trauma centers all across the nation, and these are ranked level 1 to level 4, and you'll find all of that in your book as well. Kinematics, this is looking at the mechanism of injury. So it's about how hard a trauma happened, meaning the speed of the car, and what it hit was the, so if a car hit a brick wall compared to compared to a car hitting a body of water, that's two very different MOIs, because that force is very different. 3 factors play into this: the velocity of the injuring force, the flexibility of the tissue, and the shape of the injuring force. And so it's really important for the surgeons to understand that MOI, because it does help understand kind of more of like how that trauma was sustained, so that as they're going into the body, they're really putting the picture together of what to look for. There's 2 different types of trauma. There's blunt trauma, and then there's penetrating trauma, and those kind of speak for themselves. Blunt would be an example of that, would be a head injury that I've heard people say many times, well, they look perfectly fine. Doesn't look like there's anything wrong. Well, the trauma was blunt, meaning there was no penetration. So there's no skin break. There's no way to even know that they are injured until you start assessing their cognitive function. Penetrating trauma, though, would be broken bones that are protruding through, lacerations, punctures, things of that nature. There is a revised trauma score. So this is a way to help really assess the trauma severity. And this, as they come into triage in the ER, this is a way to really make sure that the most severe cases are taken first and are addressed first. It does involve the Glasgow Coma Scale, which is assessing cognitive function, and there's a lot of other physiological factors that all plays a role in this trauma score. And so for you, you're going to look at, like we talked about, very severe patients, severely injured patients may require multiple procedures, and they may be performed simultaneously all together or in succession. So it depends on the severity and their trauma score. You do want to be also aware of the need to preserve evidence, especially if there is some criminal activity involved, or any case that there's some evidence that needs to be maintained and preserved for investigation. You want to help prevent hypothermia. You want to help prevent infection. And so if, and this is in preparing for the case, if you're looking at a level 1 trauma, there may be 2 or more ORs that are needed, multiple setup, fluoroscopy OR table is going to be needed for those, just to be able to see what's going on while the work is done. PTSD patients, so PTSD in the beginning, was thought about just military PTSD. We're finding now that anyone can have PTSD, and traumatic situations can cause PTSD. And then at the same time, you may see that you may have a patient that is suffering from PTSD that makes it more challenging because of their psychological chaos, basically, that happens during the trauma. So they may be triggered. You may play a role in trying to calm them as well. So in summary, there is some considerations that you need to have for those special populations. Be sure that you're considering the physical and the psychological needs of each of those populations and what your role is for each of those. I think that was the last one. And so as you think about your role, just remember some of that verbiage that is very non-opinionated or non-judgmental, and so that you're not telling patients that you know how they feel or you understand, but just being sympathetic and empathetic with the patient. So at this point, I want to say the last key word, and this is going to be quite a, I'm doing my water bottle, so I'm going to stop my share here real quick. And so this is Cumberland Gap. Cumberland Gap. You gotta say Cumberland Gap to me, and I'm gonna show it to you. This is my favorite water here in the South. It's spring water that I've actually, when I was interviewing for med school years ago, I went to a school in Harrogate, Tennessee, and they bottled this water right down the street from it. So I went over there and watched that process. So Cumberland Gap is the third and final key word. And then let's see, I think that's all we're going to do. I was going to do a video, but I think that we're good. We've got a little over, we've got almost 4 hours collectively between the time that we spent together, that we'll spend together tonight, and the time that we are spending together during this lecture. So I hope that works for all of you. And we will come together next Wednesday as well and make sure that you guys are understanding this material and the homework and the cases. So thank you for your attention, and be sure to send me those 3 key words. Okay, 20 ml max, Philadelphia, and Cumberland Gap. Thank you all.